Okay, well, it's a real pleasure to participate in this video conference. We all are being affected by COVID. I think it's important that we share our experiences and learn from each other in addition to the literature, because we are all in this together and all have things to learn that are new on a daily basis. As someone said, we are flying the plane while we are building it.
Құрметті әріптестер, ханымдар мен мырзалар, жаңадан ашылған Galamdyq-sheshim COVID-19 ақпараттық арнасындағы бүгінгі алғашқы іс-шарада бізге қосылғаны үшін алғыс айтамыз. Мен сіздің жүргізуші Динара Демеубаева, дәрігер зерттеуші бағдарламасы бойынша бірінші курс магистранты. Бүгін бізді белгілі баяндамашы Ларри Ленс МcGill университетінің балалар пульмонологиясының профессоры Монреаль, Канададан қонақ болып келіп отыр. Біз сондай-ақ Нұрлан Дәулетбаевтың біздің байланыстырушы буынға айналғанына қуаныштымыз. Профессор Дәулетбаев Марбург қаласындағы Филипп университетінің трансляциялық зерттеулер зертханасының директоры, МcGill университетінің және Қазақ ұлттық университетінің профессоры. Көрермендерге айтарым, біздің бейнеконференциямыз YouTube арнасында тікелей көрсетіледі, ал ағылшын тіліне аударманы екінші жүргізуші Әл-Фараби атындағы қоғамдық денсаулық сақтау бағдарламасының бірінші курс докторанты Айгерім Алияқпарова жасайды. Уважаемые коллеги, дамы и господа, благодарим вас за то, что присоединились к нам на сегодняшнем первом мероприятии в нашем недавно открытом информационном канале «Глобальное решение COVID-19». Я ведущая Динара Демеубаева, магистрант первого курса по программе «Врач-исследователь». Сегодня нам повезло иметь известного докладчика Ларри Ленса, профессора детской пульмонологии в университете МcGill, Монреаль, Канада. Нам также повезло, что Нурлан Даулетбаев стал нашим связующим звеном. Профессор Даулетбаев является директором лаборатории трансляционных исследований в университете Филипп в Марбурге, приглашенным профессором в университете МcGill и в Казахстанском национальном медицинском университете Аль-Фараби. Обращаясь к аудитории, я хотела бы напомнить, что наша видеоконференция транслируется в прямом эфире на канале YouTube, а перевод с английского будет сделан нашей второй ведущей, докторантом первого курса программы общественного здравоохранения Казну Аль-Фараби Айгерім Алияқпаровой. Ал келесі сөзді құрметті профессорге Нурлан Даулетбаевке беремін. Я передаю речь нашему уважаемому профессору Нурлану Даулетбаеву.
Thank you. Professor Lance, thank you very much for agreeing to contribute to our very first live information session.
It's a pleasure to be here.
We plan to transform this information channel into a vehicle for knowledge translation between McGill University and Kazakhstan.
I think this is a perfect opportunity and a wonderful platform to be able to share our knowledge and our experiences.
Your participation in this session is very much appreciated, and I will let our hostess, Dinara Demeubayeva, tell the audience about the program.
Бірінші бөліміміз ең соңғы әдебиеттерді талқылауға арналады. Көрермендерімізді YouTube арнасында түсініктеме түрінде сұрақтар қоюға шақырамыз. Біздің әріптестеріміз осы сұрақтарды жинап, топтастырады. Наша первая часть будет посвящена обсуждению самой последней литературы. Мы призываем аудиторию размещать вопросы на канале YouTube в виде видеоконференции или комментарии. Наши коллеги соберут и сгруппируют эти вопросы. Келесі кезең презентацияны ұсынамыз. Представление презентации.
Professor Lance, just to make sure that our translation can keep up, we will ask you, and I will also try to speak very slowly.
Yes, I hear you. I understand.
So for now, I will switch to presentation, and I prepared those slides. Some of these slides I will present myself as an introduction to your main presentation, and then you will take over.
Okay.
Okay, so that's, I'll put my presentation on the full screen. And please don't be surprised that you see two slides in different languages. This is for the sake of our audience.
Mm-hmm.
it will be like this. As you see, we'll have a brief discussion of published knowledge. You will discuss epidemiology, clinical manifestations, and then we'll discuss what children should we consider as vulnerable population, as well as return to daycare and school. Yesterday, you and I had a very good discussion about safety recommendations, both for children and for medical personnel. So if you can maybe elaborate on safety recommendations, that would be very much appreciated. And if you can share your recommendations on clinical safety and infection control. And if we will have questions, we'll have a live question and answer period. Is this working for you?
That'll be fine.
So I'm just showing the slide again with our agenda so that the audience will have time to catch up. And so I'm moving on to the next slide. We will try as much as possible to abstain from professional terminology because our audience is mixed. We will have students as well as professionals, and some of general public is watching our presentation live. That's why I put together this slide with various terminology that you will probably mention, such as PFT, such as PPE, and here is the translation of this terminology. And this is just a brief introduction, why we need to keep an eye on literature. Ideally, when we deal with literature, medical literature, we want to have evidence about our diagnostics and treatment as strong as possible, while the bias or systemic error should be kept as low as possible. And if we have an experience from any single country, be it Kazakhstan or even China, we still risk having very high bias, while our evidence base may be very low. So here is again in a different language, so our bias will be very high and our evidence base will be very low. In case of countries like Canada, because Canada has been a birthplace for the concept of evidence-based medicine, I would probably think that this bias is lower and the evidence base is higher, but still it makes sense to consider all evidence that is available to date. And this is great that we have you, because I will show the role of an expert in critical appraisal of the literature. Because we want to have a systematic review, we want to have hard evidence, we want to be comprehensive, and we want to have as low bias as possible. And here's the slide again in a different language. And the problem with the current pandemic is the following. There is an avalanche of data. I believe that every day, something like 2,000 papers are being published, all dedicated to COVID-19. This is the map, world map that we made on the April 10th. Right now, we have almost doubling the numbers. So another problem that we have is, apart from excessive volume of published data, is that many publications, they are very timely, but have different limitations. And yet another problem is how to find out the publications on pediatric population. And here is the slide again in a different language. And concerning the pediatric population, I made the slide as a comparison. We have a great body of evidence from adult patients. It looks like the planet Jupiter, whereas in comparison, the pediatric data is very small. It's like Earth in comparison to the planet Jupiter. So what can we do in a situation like this? So we can ask an expert, such as yourself. And I would like to introduce you to our audience. You're not just a pediatric respirologist, and an expert in genetic and rare diseases of the lung. You also direct Division of Pediatric Respiratory Medicine in Montreal Children's Hospital. You're also director of the Cystic Fibrosis Clinic. You're director of a neuromuscular clinic, and you're an attending physician of transplant clinic. On the research side, you're a chair of Canadian Thoracic Society Research Committee, and you're full professor at McGill University. We are very happy to have you with our presentation, and I would like to now pass the microphone to you, and I will just continue showing the slides, but if you would like to start discussing the published data, that would be the perfect time.
Thank you very much. You have to realize that the literature is, as Dr. Dudley said, quite scattered. It is also based on the testing procedures in each country. So some countries are doing mass testing. Germany is planning to go to 500,000 tests per week, which is amazing, but also will provide very valuable data. Many countries are either not testing or they are only testing those who are symptomatic. And so it is very hard to understand what is the background prevalence of COVID-19, and even more so, what is the background prevalence in children.
I'm just switching the slide so that the audience can appreciate the translated slide. We'll give them a minute or so.
Because COVID-19 did start in China, the majority of data that we know has been amongst children. I will just mention in Canada, where we've been only testing symptomatic, only just under 5% of all the positive tests have been children. So as Dr. Doutlev showed with the planet ratios, this is true in Canada as well. This paper from China, which was one of the first papers published, shows that the majority of children have relatively mild to moderate disease.
So I'll just switch so that the audience will see that the majority.
If you look at the bottom row, you can see that 5.3% were considered severe, but I have to say their criteria for severe was an oxygen saturation less than 92%.
I'll help our translator with discussing diagnostic criteria, or how to define what's severe, how to define what's moderate, what's mild. Can you please translate this? And our keynote speaker mentioned that depending on how you define the severity, you may end up with different percentage. Am I correct on saying this?
Yes. Okay, and you will see in the column next to it, the 0.6% are those who needed intensive care. So unlike the experience in adults, especially older adults, children tend to be less severely affected. There's been much interest in what happens to newborns.
Okay.
Firstly, there does not seem to be what we call vertical spread. So there does not seem to be COVID virus in the blood of the mother, in the amniotic fluid, or in the breast milk. And it seems that infants born to mothers who are COVID positive acquire the virus postnatally, probably in contact with the mother or other adult family members. In fact, the literature from China found that those children who were admitted all contracted their disease from adults who they were living with.
Mm-hmm. I'll just help our hostess to summarize this. So based on your on what you just told us, there is no direct transmission from a pregnant woman to her child, not yet unborn child, not yet born child, okay? But the transmission happens during the contact after birth.
Okay, if you go down the column, delivery-related information,
Yep.
that section, yes, that section, where you just had to.
Yep. Mm-hmm.
Okay.
Yes, yes, okay, this one.
Okay.
Mm-hmm.
I think it's important to point out that many of these women who were COVID positive, and they were generally often symptomatic, often resulted in a cesarean section for a delivery.
Mm-hmm.
And you will note that many of the infants were born prematurely. So
again, to emphasize for the audience, we're looking at this line that shows that 100% of these women delivered their babies by cesarean section. And the babies were born prematurely.
As far as we can tell, just like all prematures, there seems to be a risk of respiratory distress that is treated in the usual way that people are treating neonatal distress.
Should I stay on the same slide or continue with
the
next?
that's we can move on to the next slide.
Okay, so that's the next slide.
This is one of the largest studies. This comes out of the Centers for Disease Control in the United States. And as you know, the United States has been more affected than many countries. So it is one of the largest collections of data. Again, it is based on those who have been tested and tested positive. I would like to repeat that and make clear that many children have what is called asymptomatic carriage. In other words, they will be COVID positive on testing but have no symptoms. This can also occur in adults as well. The first thing you will notice on the slide that it's a very small number of children, 291 under the age of 18, versus the number of adults in this study of almost 11,000. As you can see here, children are a little less likely to have fever, cough, and shortness of breath compared to the adults. And you can see not only collective
73%
versus 93%. And you can see in each of those, in the next three columns or rows, fever, cough, shortness of breath, they are all less frequent in children. The adults seem to have much more myalgia, and many adults will report that this is the worst flu they ever had in their life. As you can see, again, runny nose is about the same, but sore throat and headache appear to be less in children.
So running nose, 6.9% in adults, 7.2% in children. Sore throat, 24% versus 35%. Headache, only 28% of children reported headache, but almost 60% of adults reported headache.
In terms of gastrointestinal symptoms, I'm a little surprised that the numbers are so low, because the Chinese literature particularly mentioned diarrhea and viral shedding in stools, although it can be, and it can be actually the presenting symptom and not necessarily respiratory in children.
So you're surprised that 11% it was.
And especially the diarrhea was only 13 versus 31. But like I said, certainly gastrointestinal symptoms are part of this and sometimes can be the presenting symptoms only. So it can look like a viral gastroenteritis.
So then just to summarize, you are surprised that US data demonstrates a low frequency of gastrointestinal problems in children.
Yes.
In comparison with Chinese data. And then my question would be, so I hope that Aigerim will have time to translate this. Do you think that different countries have different genotypes of the virus?
There seems to be some mutation going on. So there are changes in genotype. We would all love to know, is that explaining why there are some differences between countries? But it seems that the COVID-19 can mutate, and so that not all COVID-19 are the same strain. So we even within country, I would guess.
So we can assume that this could be because of a different genotype of the virus, that US data shows such a low frequency of gastrointestinal symptoms in children.
Other things like diet, environment, etc., can also contribute to predisposition to gastrointestinal symptoms as a background.
Should I move on?
Yes.
Okay, so we're moving to the next slide. We will try to define who are these vulnerable pediatric populations. So how would you define a vulnerable child?
So this has been difficult, and many organizations have been trying to define for their population who is at risk and who is not. Most of us will agree that immune suppressed children are at increased risk. It seems particularly for those who have suppression of their innate or T-cell immunity, but it is not entirely clear, but it is hypothesized that it is those groups that would have the most problems, especially since the cytokine storm seems to be along the process of innate immunity, which is when disease becomes very rapid and aggressive.
So just to summarize again for our hostess, different specialties, medical specialties define somewhat differently what is a vulnerable child.
I'll just
want to give her a minute or two so that she can catch up. And that immunosuppression, either innate immunity or T-cell based immunity, immunosuppression seems to be that makes a child vulnerable to this infection. And then the question is, can you maybe give clinical conditions that you have in mind for immunosuppression?
Yes, so I will give you a very practical example. A child followed in our rheumatologic service who's on immune suppression, and I believe that means they're on biologics, actually required admission and mechanical ventilation in the intensive care unit.
You think that this child had immunosuppression because of the use of a biologic drug?
Yes.
Okay.
So, and I would say similarly for those children who have undergone chemotherapy for malignancies as well.
For hematologic disorders.
Or other cancers.
Or other cancers, okay. Okay. What about something closer to home, respiratory?
So The vast majority of children with asthma, we feel, do not appear to be at increased risk for having severe disease. There are about 10% of children with asthma that we would classify as severe and at risk. When we talk about should we continue to shelter these children or should we allow them to go back to school, we are being very cautious about that. And currently we are not going to allow them to go back to school for right now. By September, they probably will be going back to school.
This is a very important information. If you wouldn't mind maybe repeating this in shorter beats, because there are many kids with asthma in Kazakhstan, and so that our hosts will transmit this knowledge very clearly.
Most children with asthma are not at increased risk for having worse disease should they catch the virus. There is a small group, about 10% of children with asthma, who we do feel are at risk. It is this population that we feel for now should not return to school.
I will just ask Igarin to confirm that she got this message clearly. These children, these 10% of vulnerable children with asthma, the Canadian respirologists recommend not to go to school until September. The next group is
cystic fibrosis, and I understand that there is not many children with cystic fibrosis
in Kazakhstan.
Here again, many of these children should be able to go to school, but we have made some recommendations of those who are at risk, such as those children who are less than 2 years of age, those who have low lung function under 60%, or have had a large drop in their lung function in the last year, those who are frequently hospitalized, and those with diabetes.
It's very interesting that you mentioned diabetes, although this is diabetes that is associated with cystic fibrosis. I'm just explaining this to our translation, because there are several questions coming in on our live comments about diabetes.
And we will talk about diabetes very shortly on the list there.
Okay, very good.
So let's because there are some important things to point out. For children with bronchopulmonary dysplasia, we're recommending that those who should stay home are those who are under 2 years of age, those who are in hospital a lot, those who don't tolerate viral infections so that they often end up having to come to the hospital. And for older children who are older prematures and old enough to do lung function, if they have significant disease, again with lung function less than 60%, we would recommend that they stay home as well.
So it seems to me that several of these recommendations revolve around a pulmonary function test being less than 60%.
Yes.
Second, it's the age, less than 2 years. And third is whether or not they had some decline in health in the preceding year, you said, right? Or so, and that applies to both cystic fibrosis and bronchopulmonary dysplasia.
And I would say also to primary ciliary dyskinesia as well.
So if they're old enough, the question is if they're old enough to do PFT. If they're not old enough to do PFT, what should you do if PFT is not feasible to do in a child?
Then you have to base it on their symptomatology, their tolerance for getting a viral infection. If every viral infection results in them having to come to the emergency room, they should avoid.
Okay, so meaning that in a child that is old enough and cooperative enough to be able to do a pulmonary function test, your primary criterion would be less than 60%. But if a child cannot do it, then you would base your recommendation whether or not to go to school on the previous history, whether or not this child had viral-induced disease or emergency visit or hospitalization. And but you also listed children in need for oxygen, which do not belong to any of these groups. Who would be these children?
So sometimes they're children with upper airway obstruction. They might have, let's say, trisomy 21, Pierre-Robin syndrome or sequence.
Genetic disease.
Genetic diseases or other congenital malformations that requires them to be on oxygen or ventilatory support. That could be non-invasive ventilatory support like CPAP or BiPAP, or it could also be meaning invasive ventilation, let's say through a tracheostomy. The one group that we do not feel is at increased risk is those who require CPAP for obstructive sleep apnea without any underlying comorbidities.
So, and again, I will summarize this for Aygerim. The children in need for oxygen or ventilatory support, I can switch here, so she will have easier time. These children do not belong to these four groups. These children would be those with, for example, malformation, genetic disease, who would need oxygen or non-invasive ventilation. And
or
these,
also invasive ventilation.
Or invasive ventilation. And these children would also be considered as vulnerable children. So I'll go back. And what about sickle cell anemia?
The American Sickle Cell Foundation has come out with a clear statement saying that sickle cell disease is a risk factor for more important problems with COVID-19. Sickle cell trait is not. And in sickle cell disease, they included all the forms of sickle cell disease.
Okay, I'll probably need to explain this. As trait, you mean a sibling?
No, trait, you're a carrier.
Carrier, yeah. So but for example, a brother or sister that who has no disease. Okay, so
exactly.
And I just checked, I have approximately 6 or 7, no more actually, question about diabetes.
Okay, so diabetes, from the adult literature, diabetes is a risk factor for more severe disease.
But may I interrupt you here? Diabetes type 2 or?
This exactly is what I'm going to address right now.
Sorry, because
that is why I wanted to address diabetes in and of itself.
Okay.
You have to realize that the diabetes as a risk factor is typically type 2 diabetes in older adults who often have comorbidities, particularly obesity and hypertension, both who are also increased risk factors for more severe disease.
Okay.
At this point in time, it is unclear if children with type 1 diabetes have this increased risk or not. So there are subtle differences. We just don't know enough now Matter of fact, I read a discussion this morning, particularly about that. And a diabetes expert pointed out that that difference between type 1 and type 2. And we just don't have enough information right now about type 1 diabetes. You have to realize not many children have been hospitalized despite large outbreaks in Europe. So it's suggestive that children with diabetes, which is a common disease, type 1 diabetes, does not seem to increase risk. There hasn't been that signal yet, but I think the data is too scattered and not known to be more definitive on that.
So what we discussed is that immunosuppression seems to be a very clear indication for these children not to go to school. Immunosuppression, it is both innate immunity and T-cell based immunity. You also mentioned that by your estimate, only about 10% of children with asthma, you would consider them at risk for COVID-19, about 10%. And we discussed the criteria, they're listed here. Cystic fibrosis, bronchopulmonary dysplasia, and primary ciliary dyskinesia. These three diseases, you gave recommendations based on age, less than 2 years or above 2 years, and whether or not they can do pulmonary function tests. And an important criterion was prior viral induced disease, prior exacerbation, worsening of the disease due to viruses. And I will just emphasize, you meant not just COVID-19, you meant something like common cold.
Yes.
Cold-induced asthma, for example. About the line, children in need for oxygen or ventilatory support, I'll just switch to the other slide. You mentioned that these are children could be at this condition because of genetic disease or because of malformation, and ventilation can be invasive or non-invasive. About sickle cell anemia, you mentioned that there was a statement from the American Association on Sickle Cell that stated that someone who has active disease is at risk. Someone who is a carrier is not. Diabetes, you mentioned that we only have data from diabetes type 2, and I completely agree with you, because older individuals with diabetes, they may also have the immune system changed or modified because of diabetes. We don't have enough information about diabetes type 1 diabetes. If Aigerim is okay with, did you get all this information in summaries? Okay, perfect. So we can move on, elaborate a little bit on asthmatics. And I think it's important to emphasize viral-induced asthma. It's not about COVID, but viral-induced asthma from the history, from the past history, such as from common cold-induced asthma.
Yeah, so we decided that those children who were at risk were vulnerable asthmatics. One, as evidenced by frequent trips to the emergency room. If they needed to actually go to the intensive care unit for their asthma in the last 2 years, we thought that they were vulnerable. If they're on high dose of inhaled corticosteroids, and I believe we have a slide coming up to discuss that.
Yes, we have a slide, yes.
Yeah. If they're using biologics, such as Xolair, and the occasion there are patients who are on regular systemic oral corticosteroids, they would also be considered a high-risk asthma group.
I will now switch to the slide in a different language so that Nagarin will be able to finish off her translation. Okay. And this is the table that you mentioned.
Yeah, so I won't go through the details, but different molecules have different thresholds for what is considered high dose, and that is listed here. I've listed these using the trade names that we use in Canada, not as an endorsement, same thing for Xolair, but we were developing this as patient information, and we wanted to use terms that our patients would understand.
Okay.
For children under the age of 6, those thresholds are half the thresholds that we have for those over the age of 6. We just reviewed conditions that we feel represent children who are increased risk for more severe disease should they be infected with the COVID-19. And if we can just go back to the other slide for a second. We felt that would be important. Now, you have to realize our school year in Canada goes September to the end of June. The government is now planning on opening schools in mid-May till the end of June. So we addressed this towards that window. We felt that healthy siblings go to daycare or school. It's very important that everyone practice good hygiene. So when they're out of the house, social distancing, they may need to wear masks. They certainly need to practice very good hand washing, which is 20 seconds with warm water and soap, which is quite effective. We feel it's very important when someone comes in from the outside that, again, they practice proper hygiene, and particularly washing hands as soon as they come into the house, because we know that very often siblings can bring home viruses, just regular viruses from outside.
May I ask a question? How do you feel about children wearing masks, let's say during some, not in class, but outside? It can be raining, they can be running, the mask can get wet. Do you think it will still be as effective as a protection, or do you think it should only be in class when they're very close to each other?
I think a wet or soiled mask is useless and offers no protection. I think, it is one thing to be out in fresh air as long as children are not very close to each other, that there's less risk of spread amongst children. We do not know how much, because we have been doing this isolation, we really do not know what the potential is for spread amongst children, especially if you consider that many children will have asymptomatic infection. While they are positive, their viral load might not be as high. So they might not be as contagious, but this has not been proven as yet. In the classroom, which is more an enclosed space, again, social distancing. What I've seen, especially, let's say in Taiwan, and now that they are reintroducing schools in parts of Europe, that the children are wearing masks in class and that the teachers also wearing a mask. Class size has been decreased by half so that they can spread out the desk. The children also eat their lunch at the desk. So they are trying to limit spread within the classroom as well.
So just to summarize, we mentioned before that the children may be less vulnerable apart from the children who have the diseases that we discussed before. You just mentioned experience from other countries where they try to increase the social distancing by reducing the number of students in the class. Apart from that, you mentioned that in a class, wearing a mask may help, or eating a lunch at your desk may also help to decrease the likelihood of infection spread. And we also discussed some, yesterday we discussed some of the recommendation about medication check. It seems to be self-explanatory, but many children or many parents forget to check this. I guess recommendation would be not to have an expired medication or empty medication. So how soon do you think updated recommendation will be available?
I think probably by early summer, as we get the experience from places that have returned to school. I will note that Taiwan never stopped their schools, but did practice social distancing. They did wear masks. Their culture was very much attuned to wearing masks for viral illnesses. And they seem to have kept viral spread quite low.
So you think that in early June, we can reach out to you again, and if you have further recommendation, we can benefit again from your expertise?
I think, yes. I think probably closer towards the end of June, just because it'll give us about 2 months of experience. Actually, in Quebec, they are not going to open up the high schools or universities. It's just the primary schools, so it's the first 6 years of school. They felt it was too difficult for adolescents to practice social distancing.
Ah, interesting. I would have thought otherwise.
Yeah.
But what about daycare? We talked about school, and what about daycare?
So daycare, you have to realize that we have government subsidized daycare. And so the majority of young children under the age of 4 are in daycare. And other than the at-risk groups, we are recommending other children can go back to daycare. We are more concerned about the daycare workers than the children, and they will have to practice excellent hygiene.
So, and since we're at infection control, and you just made a statement about children and adults, such as in a daycare, what about children visiting their grandparents after quarantine?
I don't think anyone feels at all comfortable that the children should be visiting their grandparents if the grandparents are over 60 years of age or who have at-risk factors.
So better not. So better abstain from that.
Yes.
So it's important to emphasize, I'm agreeing, if grandparents have conditions, they're above 60 years old, do not visit.
I would just like to mention the Swedish experience, and Sweden has had a much more open policy than the majority of countries. Even there, they have shielded and protected those who are 70 years and above. So even in one of the most open environments, they are protecting their older people.
That will continue into the next topic of our discussion, child safety and infection control. How to protect the medical personnel. Can you maybe elaborate on that, on this important topic?
Yes.
Medical safety.
Yes. So we continue to have outbreaks. Actually, they've just announced outbreaks within hospitals. So even where people are aware and have access to personal protection equipment, there have been breakdowns in infection control and spread both amongst personnel and also between patients.
I will emphasize this in a second to agree, because This is also a very relevant issue for Kazakhstan. We just heard from Professor Lenz that even in Canada, there are instances of outbreaks meaning infection spread amongst medical personnel or between patients. And what do you think is the reason for that?
I think there's sometimes just small lapses in control is probably the highest. I would also say that some patients come in and are considered or tested COVID negative.
Okay.
And several days later, they retested,
yes,
and they are positive.
That makes sense. That makes sense.
I've just heard of examples like that. I think on this slide, the last line is very important to emphasize that just as you will have so-called hot and cold wards, so COVID positive wards and COVID negative wards, I think also it's important to keep healthcare teams also separated along hot and cold. And one of the ways that we've seen spread is that people have been working and going back and forth, say one day on a hot ward, one day on a cold ward, and this has caused problems.
Before I get him, please hold on translating this. Before she will start translating this, I think in Kazakhstan situation might be different in that I believe I will get confirmation from our colleagues. I believe they assign specific medical centers to tending to those who are COVID positive. So basically, it's the whole center dedicated to just COVID. I'm not sure whether personnel transfers between both. Can someone please confirm this to me? Whether it's the whether I'm gathering the situation right? That in Kazakhstan, specific centers are assigned to COVID. Okay, so they are confirming this. So there will not be the situation when you have the same medical personnel going back and forth between COVID positive and COVID negative patients. The last is not.
Okay, and that's actually if you can do that, that is excellent. Now, the level of protection that is needed, it depends on what you are doing. So in particular, N95 type of masks should be reserved for those who are interacting with patients who are likely to generate aerosols.
So you would use N95 only for procedures that generate aerosol?
Yes.
Such as?
This could be nebulized medication.
So inhalation.
Inhalation. It could be CPAP or BiPAP.
Non-invasive ventilation.
Non-invasive ventilation. There was some debate about whether high-flow nasal cannula oxygen or air was aerosol generating. It is generally felt not to, but no one's 100% sure.
No one is sure. Professor Lenz summarizes his experience from Canada, under which situation to use the respirator mask, N95. He thinks that they use these masks only during the procedures that generate aerosol. And I asked for specific examples. It could be specific types of inhalation. It's called wet inhalation. Non-invasive ventilation. No one knows for sure whether when a patient is given oxygen, high flow oxygen, whether this generates aerosol, no one knows for sure. And you also mentioned that to me in our previous discussion that the pulmonary function test is an aerosol generating procedure.
Yes, it is. You're asking people to take in big breaths, breathe out hard. It often generates a cough. For those who have chronic lung diseases, it's aerosol generating.
Okay. So with that, we'll move on to our hostess, Dinara, to our second hostess.
Yes. Осы өте қызықты және мазмұнды пікірталас үшін көп рахмет. Бүгін біз эпидемиология және әртүрлі клиникалық көріністер туралы мәліметтерді қысқаша талқыладық. Қандай балалар осал болып саналуы керек? Балалар ересектер және медициналық қызметкерлерінің қауіпсіздігі бойынша ұсыныстар, сондай-ақ клиниканың қауіпсіздігі және инфекциялық бақылау бойынша ұсынымдар. Большое спасибо еще раз за эту очень интересную информативную дискуссию. Мы сегодня вкратце обсудили опубликованные сведения об эпидемиологии, различных клинических проявлениях, какие дети должны считаться уязвимыми, о рекомендациях по безопасности детей, взрослых и медицинского персонала, а также рекомендации по безопасности клиники и инфекционному контролю. Өз сұрақтарыңызды бейнеконференциядан кейін көрсетілетін электронды поштаға мекен-жайына жіберуіңізді өтінеміз. Біз оларды профессор Ленспен жалғастыру ретінде талқылап және барлығыңызға жауап жібереміз. Пожалуйста, присылайте нам свои вопросы по адресу электронной почты, который будет показан после видеоконференции, и мы обсудим их с профессором Ленсом в качестве продолжения и сообщим ответы всем. Құрметті бейнеконференция қатысушылары, біздің кездесуді аяқтай отырып, біздің спикер профессор Ларри Ленс конференцияға қатысқан үшін және COVID-19 және педиатриялық пациент тәуекелге ұшыраған балалар туралы ойлаймыз тақырыбы бойынша өзекті сұрақтарға жауап алу мүмкіндігі үшін тағы да алғыс білдіруіміз керек. Бізді байланыстырып Galamdyq-sheshim KZ YouTube каналын көрген конференция қатысушыларына алғыс білдіреміз. Біздің ақпараттық арна Galamdyq-sheshim KZ жұмыс жалғасуда. Алда әлемдік сарапшылар мен ғалымдармен кездесу күтіп тұр. Сіздің сұрақтарыңыз және қызықтыратын тақырыптарыңызды поштаға жіберуіңізге өтінеміз. Galamdyq-sheshim KZ @gmail.com деген адреске жіберуіңізге өтінеміз. Сау болыңыз және өзіңізді сақтаңыз. Уважаемые участники конференции, завершая нашу встречу, позвольте еще раз поблагодарить нашего спикера, профессора Ларри Ленса за участие в конференции и возможность получить ответы на актуальные вопросы по теме COVID-19 и педиатрический пациент. И думаем про детей, подверженных риску. Благодарим участников конференции, кто был на связи, смотрит нас на YouTube-канале Galamdyq-sheshim KZ. Наш информационный канал Galamdyq-sheshim KZ продолжает работу. Впереди еще нас ждут встречи с мировыми экспертами и учеными. Ваши вопросы и интересующие темы высылайте на почту Galamdyq-sheshim KZ@gmail.com. Будьте здоровы и берегите себя.
Dear Professor Lenz, thank you so much for helping us to start this wonderful session and for all your questions and sharing the knowledge with us. Please stay healthy and positive and safe.
Thank you so much. It was a real pleasure to participate in this activity.
We wish you a great day, and with this we will adjourn our session. Goodbye to everyone.
Bye.